The past 2 decades, PET-CT has become an essential modality in the management of GI cancers, including staging, therapeutic response assessment, restaging, and surveillance. However, usually remember that certain malignant tumors are known to have low FG uptake, such as early-stage esophageal adenocarcinoma, mucinous tumors, indolent lymphomas, and multicystic mesotheliomas. And on the other hand, post-response assessment, mainly after neoadjuvant therapy, such as inflammatory changes, post-operative complications such as abscess or fistula formation, which may obscure underlying malignant lesions. Sorry. Also, we have to know technical artifacts from, for example, high attenuation contrast within bowel loops and artifact from patient movement. It's important to know the common variants and benign diseases that can mimic malignant tumors, such as intense FG uptake in the esophagus and the stomach in cases of esophagitis and gastritis, the use of metformin, which can cause intense uptake through the bowel loops, intense physiological uptake through the anal canal, segmental bowel uptake in cases of IBD, radiation enteritis, and colitis, and even the normal structures, the appendix and diverticulum, can show FG uptake. So in the absence of clinical suspicion arising tumor markers, the role of FG PET-CT in routine surveillance of patients with GI malignancy is still not clear. We have to know each step in PET-CT, starting from patient preparation, acquisition parameters, image reconstruction, image quality quantification, interpretation as inter-observer variability to avoid false positive or false negative results. According to the American College of Radiology practice parameters for performing FG PET-CT in oncology, the CT component of PET-CT is used either for diagnosis or for attenuation correction and anatomical localization. If it's used for attenuation correction, we have to use low-dose CT without affecting the image quality in order to reduce exposure dose. And if it's used as a diagnostic tool, we have to use the full diagnostic protocol according to each case. We may inject intravenous contrast, bowel preparation, the use of oral contrast. And so PET-CT examination can be tailored by the radiologist according to the clinical data of the patient. And now I'll go through some of neoplastic and non-neoplastic lesions. These are gastric uptake in different patients. The first one is physiological uptake. The second one is gastritis, while the third one is radiation gastritis. 3 different tumors: intense uptake in gastric schwannoma, mild uptake in gastroesophageal leiomyoma, and the last one is multilymphoma with mild uptake. Mild uptake in a case of duodenal tubulovellus adenoma, intense uptake in duodenal gastrointestinal stromal tumor, and carcinoma. 3 different patients with intense uptake at the level of ileocecal junction. The first one is physiological uptake, the second is benign adenoma, and the third one diagnosed as a metastatic lesion. Physiological uptake through the bowel loops in patient on metmorphine, and don't forget artifact from positive contrast in bowel loops. Another patient with diffuse uptake through the bowel in case of ulcerative colitis, and the segmental here in the sigmoid colon. This patient had a peritoneal nodule with intense uptake, and on follow-up, there is decreased size of the nodule with decreased uptake, but there is increased uptake at the level of the ascending colon, and this case diagnosed as post-radiation colitis. On the second follow-up, there is resolution of radiation colitis and regression again in the size of the nodule and its activity. And now I'll take rest from malignant lesions and I'll show you some normal structures which show uptake of FG in PET study. This is a splenule at the pancreatic tail, normal appendix showing FG uptake, post-surgical hernial repair, and this is a mesh showing intense uptake. And this is ovary, with transposition of the ovary at left paracolic gutter showing intense uptake. We have to know these normal structures to avoid false positive results. This case of diverticulitis with intense uptake that shows resolution after treatment. And this is an abscess, post-operative complication. And now this is a case of rectal mucinous type of carcinoma with characteristic T2 hyperintense signal in T2, showing mild uptake in PET study, and compare this with adenocarcinoma that show intense uptake. And usually differentiate this from intense uptake, physiological uptake in anal canal, and hemorrhoids, or post-management complications such as radiation proctitis and rectovaginal fistula, which is nicely demonstrated here in PET study. These are different peritoneal lesions with different grades of uptake, starting from benign conditions such as mesenteric panniculitis, fat necrosis, through malignant lesions such as peritoneal carcinomatosis, peritoneal mesothelioma, and metastatic lesion as the operative bed of pancreatic cancer surgery. It's logic that different pathological tumors have different grades of uptake in FG PET-CT. But what about the same pathology but with different grades of differentiation? I mean that this is moderately differentiated or well differentiated, and this is poorly differentiated HSC. In the first one, there is no uptake. It's more or less similar to the liver. But in the last one, which is poorly differentiated HSC, there is intense uptake. This is a benign lesion, fat-containing lesion by MRI, and diagnosed as hepatocellular adenoma. Although it's benign, but there is uptake in PET study. In gallbladder, there is serial uptake after administration of FG. In first imaging, there is uptake in the gallbladder wall, which is more or less similar to the liver. And in delayed scans, there is gradual increased intraluminal uptake, which is more than the liver. These are two different patients showing uptake at the gallbladder. The first one is focal and diagnosed as gallbladder carcinoma, and the second one is diffuse uptake in case of cholecystitis. And in conclusion, the role of FG PET-CT is well established in many of the most common gastrointestinal tumors, mainly for staging and therapy assessment. There are many pitfalls that create challenges in interpreting PET-CT scans in patients with GI tumors. Awareness of these limitations and the challenges is essential. To diagnose accurately any lesion in PET-CT, we have to correlate clinical and laboratory data of the patient with interpretation of diagnostic CT with PET-CT findings. Also, we have to know when to do PET-CT, indications of PET-CT, and how to modify the examination according to each case. Not all metabolically active lesions are malignant, and not all lesions with low uptake are benign. And finally, these are my references, and thank you for your attention.
Thank you very much, Dr. Doaa. We have time for 2 questions. After? Okay. Thank you.
second talk, neuroendocrine tumors, untangling the tangles. البروفيسور دكتور خالد نوام، بروفيسور اوف راديودايجنوزيس Alexandria University ورئيس القسم.
This is the laser pointer. ده الليزر بوينتر ولا ايه؟ في ليزر بوينتر ولا ايه؟ اوكي. بسم الله الرحمن الرحيم. My